All right, so this one's just going to talk about personality disorders. There are 10 of them, but I'm going to try to help you distinguish all 10, and we group them into 3 different groups. So hopefully that will help. The first thing we're going to talk about are the defense mechanisms that typically come with personality disorders. So we have the repression, where we put things back, suppression, regression, undoing, and splitting. Splitting's big in bipolar, so, or not bipolar, I'm sorry, borderline personality disorder. Typically, clients who have personality disorders will have some form of comorbidity, such as substance use disorders, and typically have history of nonviolent and violent crimes. We have psychosocial influences, such as childhood abuse and trauma. And then biological influences, such as genetics and chemical factors. So the first 3 that we talk about are our cluster A. This is our odd or eccentric traits. So I'm going to talk about them, and I put just a few little blurb about how to distinguish between the 3. So we have paranoid personality disorder, which is characterized by distrust and suspiciousness. So paranoid. Based off of unfounded beliefs that people want to harm or deceive them. This is treated by psychotherapy over group therapy, as group therapy is typically threatened because of the paranoia aspect. Group therapy can be used later in therapy to help improve social skills, but in the beginning of treatment, we want to stick with individualized therapy. A lot of times we will see some anti-anxiety agents like our benzos for some of that paranoia. And we can use antipsychotics if there are more severe delusions that happen. So again, these people are paranoid. Schizoid personality disorder is emotional detachment and indifference. We have a disinterest in close relationships and an indifference to praise or criticism, and they're typically uncooperative. For this, we're going to use psychotherapy. And once again, while group therapy is not a good first treatment choice, it may be helpful after the fact to help the patient. So this one, they don't care. These guys are just indifferent. They don't have any emotional attachment. They don't care about relationships. They don't care if you like them or hate them. They're just indifferent. We'll use our antidepressants or second-gen antipsychotics for this. Then we have our schizotypal personality disorder. It's going to be characterized by odd beliefs that lead to interpersonal difficulties and an eccentric appearance and magical thinking with distortions, but there are no hallucinations with these. So our big piece with this is during therapies, we need to kind of protect them from criticism because other patients may make fun of them or try to harm them. We need to make sure that they are getting psychological care that's supportive because of these guys, because of their eccentric beliefs, they are very easily led into cults, which can cause harm to the patient. So we need to investigate these things. And we're going to use low dose antipsychotics. So these are your Kool-Aid drinkers. They're going to be easily to fall into cults. Okay. So now we have cluster B. There's 4 in here. Dramatic, emotional, and erratic. We have antisocial. This is going to be disregard for others. They're going to be their lack of empathy, repeated unlawful actions, deceit, failure to accept personal responsibility. That's a big one. These guys use a lot of rationalization. Typically, we're going to have conduct disorder early in life, which we'll talk about next week. Sense of entitlement, manipulative, impulsive, seductive, non-adherence to morals and values, and they may be verbally charming and engaging. We're going to have issues with boundaries, consistency. So we are going to make sure that we are setting boundaries, we're consistent with them, and that we're setting limits. We want to make sure that we're giving realistic choices and not getting into a power struggle. We want to address manipulative behaviors along with open consequences. We want to anticipate and seek team support for aggressive behaviors. And our primary concern for these guys is going to be keeping them, but also those around them, safe. We can try mood stabilizers as far as our treatment goes, but it is this one's a very hard one to treat. We have borderline personality disorder, which is going to be instability and of identity, affect, and relationships. So, and a lot of manipulation. So this is going to have those splitting behaviors, manipulation, impulsiveness, fear of abandonment. The best way you can describe borderline personality disorder is, I hate you, don't leave me. They treat others very poorly, but they constantly are fearful of being alone. We are worried about self-injurious behaviors and potentially suicidal behaviors. So these guys are the highest risk to attempt suicide. So we have to be very mindful of that. We may have ideas of reference and lots of impulsivity, so they can be a danger to themselves or others. Antagonism happens a lot in this, which is actively being actively hostile or having opposition. So when we're taking care of borderline, again, clear, consistent boundaries, straightforward communications, review therapeutic goals calmly, and respond matter-of-factly to self-injuries that are superficial, that were not meant to harm them, that were not intended to end their life. Some of our treatment is that CBT, which we've already talked about, the DBT, which is a balance between validation of who you are and your challenges, helps with emotional regulation. And then we have kind of a combo therapy called schema therapy, which involves psychotherapy, CBT, and interpersonal therapy. So, histrionic personality disorder is going to be emotional and attention seeking. The person needs to be the center of attention, and they're often seductive and flirtatious. This behavior is typically a response to distress. So we want to make sure we keep our interactions professional and ignore any kind of flirtatious, seductive behaviors. We want to model concrete language. We want to help clarify what they're actually feeling and teach and role model appropriateness and assertiveness. And we do want to assess for suicide. And then we have narcissistic personality disorder, which is that arrogance, grandiose views of the self-importance, need for constant admiration, and lack of empathy. and they're very, very, very sensitive to criticism. We want to remain neutral when caring for this clients with this disorder. We want to promote a strong self-identity. We want to avoid power struggles. We want to role model empathy. And this is very difficult to treat because they're not going to want help because they do not believe that they have any shortcomings. If we can get there, we have cognitive behavioral therapy, group therapy, and lithium. All right. So then we have cluster C. This is our fearful, anxious, insecure traits. We have avoidant personality disorder, which is avoidance of all situations that require interpersonal contact. This is going to be social inhibition. Despite wanting close relationships, they're going to avoid interpersonal contact because of an extreme fear of rejection. They typically feel inadequate and anxious in social situations. For this group, we want to be friendly and accepting. We want to make sure we're reassuring, but we don't push them. We want to accept the patient's fears. We're going to do group therapy and design exercises that prevent failures, and have assertiveness training, as well as exercises to use social skills. We have our dependent personality disorder. This is extreme dependency in a close relationship, and then it's also characterized when that relationship ends, there is an urgent search to find a replacement. So for our nursing care, we need to make sure that we're helping to address the stressors, set limits that do not make them feel punished, make sure we're aware of any transference and countertransference, use therapeutic relationships and therapeutic communication, and our treatment of choice is going to be psychotherapy. Then we have our obsessive compulsive, so very similar to OCD. We're going to have indecisiveness and perfectionism with a focus on orderliness and control. We want to make sure we're not doing any power struggles. We need to know that the patient is going to have a hard time dealing with unexpected changes. So we need to do our best to keep them in the loop of everything that's going on and don't spring changes up on them at the last minute. Okay. Our communication strategies when developing therapeutic relationships are typically challenging, especially due to the distrust or hostility. We may have feelings of being threatened or not having control. We need to be firm and supportive. We want to offer realistic choices and limit set and have consistencies, especially when there's manipulation involved. This is seen a lot with borderline and antisocial. Clients who have dependent and histrionic personality disorders, they're going to benefit from assertiveness and modeling training, as well as psychotherapy. Schizotypal is going to isolate themselves, and the nurse should respect this. We're not going to force them to engage into the group until they're ready. And then histrionic, we talked about the flirtatious behaviors. We need to make sure we're maintaining professionalism, but also maintaining the safety of the other clients around them. Because if we remember, it's not just a group of clients with personality disorders. There's the people there for everything. So if we're holding group therapy and we have someone who's been sexually assaulted or triggered or anything, and we have this person with histrionic personality disorder, they could come in and touch them unannounced, touch them without permission or consent, and that involves other issues. So we need to keep our other patients safe as well. And that's it for personality disorders.